Roger, you're going in an hour to present a poster that is quite interesting. Can you talk me about it?
Sure. In my poster, we looked at the phase 3 Yosemite and Rhine data, which looked at the use of Faricimab compared to 2 milligram of aflibercept for the treatment of diabetic macular edema. These were the two pivotal studies that led to the approval of Faricimab for the treatment of DME.
Okay.
We wanted to look specifically at what happens to patients who have hard exudates. Hard exudates we know are a problem when we're taking care of our diabetic patients. Oftentimes we can get the edema to go away, but those hard exudates sometimes persist for a long time, and especially if they're in a subfoveal location,
and
can
decrease of vision
really limit the vision for these patients. So if we had an agent that perhaps worked better at getting rid of hard exudates, wouldn't that be nice to know? So it turns out that the vast majority of patients in Yosemite and Rhine had hard exudates at the beginning of the study, which is pretty typical. All the images were graded. These were the color fundus photos. They were graded by the Wisconsin Reading Center for the presence or absence of hard exudates in the macula. And we looked just at the overall patient population, and if you had hard exudates at baseline, you tended to gain vision more slowly and reduce your CST more slowly, which is kind of intuitively what we would expect compared to the population, the much smaller population that didn't have hard exudates at baseline. We then looked to see, is there any difference in the Faricimab treated eyes versus the 2 milligram of aflibercept treated eyes? And what we saw was at 16 weeks, no difference. Not really surprising, I think, because basically all the patients who had hard exudates at baseline still had hard exudates. They take longer to go away. At 1 year, and then more so at 2 years, is when we start to see not only a reduction in the overall population, but a greater reduction in the Faricimab treated eyes. So the Faricimab treated eyes had, it was about 76% of the Eylea 2 milligram or aflibercept 2 milligram eyes still had hard exudates. It was about 10% lower in the Faricimab treated eyes. So, and at year 2, we saw basically both arms drop down another 10%. But again, this kind of 10 to 12% delta between the Faricimab treated eyes and the aflibercept 2 milligram treated eyes. So it suggests that Faricimab does a better job at resolving hard exudates, but it takes time. At least a year to see a difference.
Lipids or lipid metabolism to understand what happens, or?
Yeah, look, I think ultimately what we would love is prevention of the hard exudates in the meantime.
Because at the beginning you have this huge, it's not just water; it's water with molecules inside, and when water goes away, then hard exudates appear.
Exactly.
So if we treated people at the very beginning, we might, just prevent them.
Exactly. And in fact, we did a little sneak preview in my poster, but more data is going to be forthcoming. This was all graded using color fundus photography. We are going to be using and analyzing OCTs, looking at hard exudate on OCT. And the beauty of that is that we can actually quantify the volume of hard exudates that are present, and it won't be a binary hard exudates present, hard exudates absence. It'll actually be what happens to the volume of hard exudate over time. And we'll get that probably at ASRS in Stockholm later this summer.
Nice.
So stay tuned for that.
Yes, exactly.
A lot of big meetings in Europe this year. So.
See you.